This short presentation is going to be on the drug therapy of gout. Gout is a recurrent inflammatory disorder, and patients will have episodes of gout when they have hyperuricemia, which means that within their blood there are high levels of uric acid. What they're going to experience is severe joint pain, especially in the large toe, although it can happen in any joint. Hyperuricemia, which is defined as blood uric acid above 7 milligrams per deciliter in your male patients, and in your female patients, you're looking at 6 milligrams per deciliter. And this can occur due to two different mechanisms. First, there's either an excessive production of uric acid in the body, or you have impaired renal excretion of uric acid leaving the body, and therefore it's building up in the synovial space. The deposits of urate crystals is what is promoting the inflammation in gout, and it's triggered by a series of events, but the key feature of this process is infiltrations of leukocytes, which will accumulate and build up within the synovial area. Also, we have phagocytized urate crystals that begin to break down, and then they release lysosomal enzymes, which are destructive to that area. When you have high levels of uric acid in your blood for chronic amounts of time, they are going to become large and gritty. And when they're chronic and large, we call them tophi. They are going to form in whatever affected joint there is, and usually it's going to be unilateral. You're not going to see these typically bilaterally. And the deposits of uric crystals in the kidney can also cause renal damage. So with gout, if we can detect it early, then we can treat it early, and we can stop the process of uric crystal buildup. And then, of course, we can stop the inflammation from further progressing as well. Now, the drugs that we use have to do with either short-term relief of an attack of symptoms, or we're trying to provide long-term treatment to keep the uric acid blood levels at bay. And so in patients with infrequent flare-ups, meaning that probably within a year they have only like 2 or 3 episodes, we can just treat the symptoms when they occur. And the best way to treat symptoms of to provide short-term relief for patients that don't have chronic gout is to encourage the use of NSAIDs, or non-steroidal anti-inflammatory drugs. These are considered the first-line agents for relieving the pain and the inflammation that's associated with gouty arthritis or gouty attack. Now, we can also use glucocorticosteroids. It is acceptable to help as well, but they do have a higher risk profile, side effects, and contraindications. So just make sure that if this is your choice, you're looking at all the potential issues with the glucocorticoid for that particular patient. I also want to say that in the past, and you may be working with providers that still might tend to do this first, but this is something that was more first line previous and not so much first line now. But colchicine was considered a drug that we would use for any acute attacks. And even up to 5 years ago, that would have been my choice. But it has a poor risk to benefit ratio to use for such infrequent times. So now we have a better understanding that NSAIDs should be the first line treatment. But in patients with chronic gout, we will change our treatment therapy a little bit. And so if you say it's frequent, I would think that it's, 3 or more or over 3. And drugs that are treating hyperuricemia are going to be indicated at this time, where with infrequent flare ups, you were just trying to treat the inflammation itself, right? So, but now with chronic gout or tophaceous gout, because it's creating tophi, we are going to use a anti-hyperuricemia drug. And the drugs that we can use, our hope is that they're going to decrease the uric acid production, which will then also help increase uric acid excretion too, if we prescribe the uricosuric drugs. And these are the ones that will promote excretion from the kidneys. And then we also have drugs that will convert uric acid to allantoin, and we can talk about that when we get to those drugs. Okay. So again, NSAIDs are going to be the first line treatment, but we have to also think about, just like with glucocorticoids, who can use NSAIDs and who might be at risk. Okay, so what are the contraindications? And basically, it's going to be the same adverse effects that we've seen previously: GI ulceration, impaired renal function. Sometimes NSAIDs are known to create fluid retention, and it does increase the risk slightly for cardiovascular disease as well. But because we're only using it briefly, and again, remember, these are for the patients that have low frequency, it should be okay as long as they don't have an underlying existing GI ulceration, renal failure, and fluid retention, edema, cardiac heart failure, something like that. Now, when NSAIDs are used, again, we're trying to reduce the inflammation there. And also, it's going to help with pain. And there is a great amount of evidence that supports the use of NSAIDs being first line because it's superior to the other treatments of gout. And so make sure that when you bring it up to your patients that you are telling them that this is the evidence that supports this, because they may have been treated by a provider previously that might have chosen colchicine for their first line treatment before you were treating them. And so the common drugs that we will use, the common NSAIDs that we use for gout, are going to be indomethacin, trade name is Indocin, naproxen, sometimes it's called naproxen, anaprox, and we will also use diclofenac or Voltaren. And Voltaren is also in gel form as well, and you can see more of the preparations if you go back in your book and go over the NSAIDs, but we'll compare in just a second. In terms of patient-centered care, let's look at some of the considerations for treatment for gout. In the US, we can use indomethacin to treat our patients with gout. However, I really don't feel comfortable treating my younger patients with indomethacin, especially under 13 or 14 years old. And actually it's contraindicated in Canadian drug labeling. When our patients need gout prophylaxis, colchicine isn't going to be your first choice. It's not recommended actually for patients under 16 years old. And allopurinol you can give children under 6 years old, and the purpose is for treating hyperuricemia that is associated with cancer. So if you're kind of wondering, like, why would a kiddo have gout in the first place? Sometimes with cancer therapy, they have high levels of uric crystals that form. Probenecid can be given to children 2 years old or older for unrelated purposes. So not gout, but if I did have an incidence where I needed to treat a child with gout, this might be something I would go to. I haven't had to personally, but I would consider this because it has been proven safe for children 2 years old and older. For pregnant women, we know that we don't give NSAIDs during the third trimester. I don't even really feel comfortable giving it in the second trimester, but it can actually cause fetal abnormalities, cardiovascular abnormalities, cleft palate abnormalities after being exposed to NSAIDs. Now, after 30 weeks gestation, it's an absolute no because using indomethacin has resulted in a number of abnormalities or fetal abnormalities. But I do want to stress too an important just tidbit. In the NICU, we use indomethacin to help close our PDAs. And I just think about if you're giving it close to the end of gestation, it may close the PDA prematurely. Now, the cardiovascular flow would not, the fetal heart flow or blood flow would not function correctly because the ductus arteriosus is now closed and not patent. Colchicine and the XO inhibitors or the xanthine oxidase inhibitors, they have been proven to cause abnormalities in animal studies, but not necessarily human studies. But I will tend to not go for those because they have shown some animal abnormalities. And probenecid has not been associated with increased fetal risk, but there are some animal studies that show that there have been some adverse developments in the Cinerad. With our breastfeeding women in the US, it recommends against breastfeeding and using indomethacin or naproxen, so those NSAIDs specifically. In Canada, it actually contradicts breastfeeding mothers to take any of those drugs at all. And it really isn't recommended for a breastfeeding mother to be treated with drugs for gout while they are breastfeeding. And so if it is really bad, they may have to stop breastfeeding for a while if we have to do something immediate. But it's something that you have to weigh the risk and the benefits with your patients. In our older adults, if you use the Beers criteria, it does list that indomethacin and naproxen are considered inappropriate for patients that are 56 years and older, and it actually carries the greatest risk of all NSAIDs. Okay, so that's naproxen. And colchicine can also be dangerous as well because it can lead to impaired renal function. And so there's not very many drugs that I would use with a patient over 56 years old, except I might try like probenecid instead. I have used colchicine in my a little bit older patients, but I make sure that they don't have any renal impairment or risk for renal impairment. So it is, up to you. You have to use your clinical judgment if it's going to work out for you or not. Now, if you're wondering what the Beers criteria is, it's actually a criteria that we use for potentially inappropriate med use with our patients that are over 65. And so it's a guide for us as nurse practitioners so that we don't harm our patients. And it does show that this criteria, the evidence behind it does show that 90% of adults over 65, because they take one or more medications, we have to really be careful about how they're all interacting synergistically and opposing one another. And When we use the Beers criteria, we are trying to avoid any harmful risks and making sure that we're thinking about um, renal impairment and potentially any liver impairment. And there are about 100 medications on the Beers criteria list. So if you're interested, look that up. It is definitely something that you should know about if you're going to be prescribing medications. So the glucocorticoid of choice is prednisone, and you can give it orally or intramuscularly, so that it can be easily given in the clinic if you need to give an IM initial injection. And it's really great for relieving the pain and the inflammation for an acute gouty attack. But again, NSAIDs are preferred. If they have a contraindication to NSAIDs, then you can go to glucocorticoids. And patients that are candidates for glucocorticoid therapy, these are ones that are hypersensitive to NSAIDs, like we said, or they have another medical condition like a bleeding disorder or an underlying GI ulcer disorder, or in the past, from previous experience that they've used NSAIDs before as first line treatment and it wasn't working well. Because of the effects on carbohydrate metabolism, glucocorticoids shouldn't be used if you have a patient that is hyperglycemic or they have insulin resistance. If you give prednisone for oral therapy, that would be the preferred method, but you can give IM, and we will talk about glucocorticoids a little bit more depth in a separate presentation. So this drug colchicine that we've been talking about, anti-inflammatory agent, but we know that we use it specifically for gout, but it's not a first-line treatment anymore. We want to go for NSAIDs first and then glucocorticoids, and if that hasn't worked, then we can move to colchicine, or if there's a contraindication for NSAIDs or glucocorticoids. Now, we stopped using it because there's so many side effects, and one of those is that there was a high rate of GI toxicity from the use of this drug. Also, we can use this drug for a couple things. We can use it to treat short-term acute gouty attacks. We can also reduce the incidence of more attacks from happening. And if you are starting to feel the signs of gout, we can treat at that point so that there's not an impending attack. We can, stop it from occurring. There's also another, and it's important to note too that one of these drugs can't be used for acute and prophylaxis. Only Mitigari can be used that's a colchicine preparation only for prophylaxis, but Colchris can be used for both. This is just a fun side note. There was a Cochrane review done almost 10 years ago, and there were 5,000 participants just about that used colchicine, and it was shown that it decreased the risk of myocardial infarctions and improved the outcomes of patients that had an MI. So can be used for other things in gout. When you use high dose colchicine, it can cause a symptom relief really quickly. And this is why patients love it. And sometimes I've had talks with patients in the office about, trying an NSAID first, and they're like, no, I've always used colchicine. It always worked. I don't want to use anything else, because they know that when you use it, it's going to work really quick. And often it's just going to be a couple hours before now they can walk again or they can move again with no symptoms. And full inflammation will disappear in about 2 or 3 days. If you want to prescribe colchicine for prophylaxis, then you are going to prescribe low dose colchicine, and it will decrease the frequency and the intensity of the acute flare-ups. Okay, so it's not necessarily going to cause it not to occur at all, because some of this has to be lifestyle changes, diet, and movement need to happen as well with your patient. So if they're not adhering to diets that are low in uric acid, it just might be really difficult to keep the gouty attacks away. But it can be given for prophylaxis when the urate lowering therapy is initiated, because the the tendency for gout episodes to increase are usually going to be at this time when you start urate lowering therapies. And that's going to be the next section that we talk about. So, how does colchicine work? And that answer really is not fully understood, but we do know that it relieves and prevents gout. And it doesn't decrease urate production or removal. So that's why it's like, how does it work in the first place? But what most people think is that it might inhibit the leukocyte infiltration that is part of the inflammatory process. And it does this by disrupting the microtubules in the cellular motility. So let's look at colchicine, and we're going to then look at urate lowering drugs. All right, so we've talked about the drugs that help with inflammation, but now these drugs are to treat the hyperuricemia, and they are eventually going to help decrease the urate crystals. So they're called urate lowering therapies, or ULTs. And these are for the patients that are having very frequent amount of acute gouty attacks. And the way they work, or the purpose of this therapy, is to promote the dissolution of the urate crystals, like you can see with allopurinol and with the febuxostat. And these drugs are inhibiting the uric acid to form into crystals. Whereas we can also have probenecid, which increases the uric acid excretion out of your body. Okay, so allopurinol and febuxostat, they are considered xanthine oxidase inhibitors because we need xanthine oxidase to convert to uric acid. With probenecid, it's going to take the uric acid and promote excretion. We do, however, have a new kid on the block, and that's pegloticase, and it will convert uric acid to allantoin, which then can be readily excreted by the kidneys. So it's also going to promote excretion, but there's one more step involved, and that's the conversion to allantoin. These drugs lack anti-inflammatory or analgesic actions. Okay, so when you have a gouty attack, just decreasing the uric crystals or helping it to be removed from your body isn't going to treat the in the moment inflammation and pain. So that's why it is really a two-step process when you're treating for gout. Now, drugs that lower plasma levels of uric acid are also worth noting, and they are going to lower the plasma urate by 3 different mechanisms. And this is what you want to think about when you are prescribing these medications, and perhaps understand this prior to your next quiz. Okay, so it's all here on this slide. Allopurinol is the first urate lowering therapy drug that we will talk about, and it's currently the drug of choice when you have a patient with chronic tophaceous gout, so a gout that is producing tophi or tophi. And if we are able to reduce the blood uric acid levels in our patient, then we can help the regression of the tophi that have already formed, and really providing allopurinol will prevent the formation of new tophi to form as well. Your patients should experience improved joint function while on this medication. We're treating this hyperuricemia that is developing also secondary to cancer chemotherapy. with allopurinol. And you heard me talk about in um, the lifespan considerations with our pediatric patients, that's primarily why we would use allopurinol. And this is because with cancer chemotherapy and other blood disorders like polycythemia vera, leukemias, uricemia tends to develop during chemo. When cancer cells die, that breakdown of cell DNA is going to release uric acid into the blood, and allopurinol is used before chemotherapy begins to help decrease the hyperuricemia that is expected. Overall, the mechanism of action of allopurinol is to inhibit these uric acids to form in the first place. Allopurinol and its major metabolite, which is alloxanthine, will inhibit xanthine oxidase, and this is why sometimes it's called a xanthine oxidase inhibitor. Xanthine oxidase, or XO, is an enzyme that is required for the production and formation of uric acid, and XO will catalyze the final two reactions that will lead to the formation of uric acid. Things to think about when you are prescribing allopurinol to your patients is what other drugs might they be taking. It can inhibit hepatic drug metabolizing enzymes and delay the inactivation of other drugs. If your patient is on warfarin, this is a particular concern, and the dosage of warfarin should be reduced while on allopurinol. There are other drugs here that you can see, anti-cancer drugs that are substrates for xanthine oxidase, or XO, so it could accumulate to toxic levels in the presence of allopurinol. Also, asthma drugs like theophylline, it's a substrate for XO, and so we shouldn't combine that with allopurinol together. Allopurinol with ampicillin is also associated with high risks of rash, and if it develops, if you notice the rash, you would stop your patient allopurinol. There are some mild side effects that most patients with allopurinol will discover, and those are usually the GI things. It's pretty much tolerated though, but you might have complaints of nausea, vomiting, diarrhea, and a little bit of abdominal discomfort. Most patients on allopurinol will also say that they feel a little drowsy, they might have a headache, and they might experience a metallic taste. If you take it longer than 3 years, you are at higher risk for forming cataracts, and those are the less worrisome type adverse effects. However, there are some serious ones to know about, like bone marrow suppression, hepatotoxicity, and hypersensitivity. The most serious type of toxicity that we want to make your patient aware of is pretty rare, but it will be in the presence of rash, fever, eosinophilia, and liver and kidney dysfunction. It's called scar syndrome, severe cutaneous adverse reaction. And more likely, our patients that are of Korean, Chinese, and Thai descent will experience scar syndrome. And for the patients that we're really worried about, you can actually test the biomarker HLA-B5801 to determine if they are at risk for scar. If a rash does develop while taking allopurinol, discontinue, and most patients will recover pretty spontaneously. However, in the case that your patient continues to have this hypersensitivity reaction, we may have to treat with hemodialysis or glucocorticoid therapy to stop the hypersensitivity process. The next uricosuric agent that we're going to talk about now within a different category than allopurinol is probenecid. And probenecid also treats gout, but it does this by increasing the excretion of the uric acid from our body. If we can lower the urate levels, it will prevent new tophi from being produced and forming, but it can also help the existing tophi to regress. Also, probenecid can be used to prolong the effects of penicillin or cephalosporin by delaying the excretion of these drugs into the kidneys. So it lengthens their effect on the body. In the US, we only have the generic form of probenecid, and it acts on the renal tubules. It inhibits the reabsorption of uric acid. If it inhibits the reabsorption, it's going to be excreted, and this will help us to reduce hyperuricemia. There are some adverse reactions or effects that we need to know, but just like allopurinol, it is tolerated by most patients, and they will have similar GI type effects like nausea, vomiting, and anorexia. Most of the time, we don't hear things like diarrhea or the CNS type side effects that we saw with allopurinol. If you prescribe this to be taken with food, these GI effects are actually reduced. Now, in terms of hypersensitivity reactions, usually if they are going to have one, it'll be a rash that develops in only about 4% of our patients. You also want to be aware of renal injury that can occur because of the uric acid crystals depositing into the kidneys. And there is a risk for kidney damage, but we can minimize this by creating an alkaline environment for the urine or alkalizing the urine. We do this by consuming 2.5 to 3 liters of fluid a day. Therefore, we're diluting the serum acid levels, and we're trying to get to 6 milligrams per deciliter. Liver injury has been reported, but this is a side effect that has been found to be quite rare. Additional considerations for probenecid is that it does add risk to patients that have underlying hemolytic disorders, anemia, pancytopenia, and also it can be attributable to G6PD deficiency, which is an inherited disorder, and patients that already have known G6PD deficiency, you would not want to provide this drug for their gout treatment. Probenecid is something that you don't initiate at the beginning of an acute gout attack because it actually can exacerbate the attack further. When you want to use probenecid for the first time, remember we're also giving like an NSAID or a glucocorticosteroid as well. If they are having an acute gout attack and you want them to use probenecid eventually, you have to wait until the attack is well under controlled. If your patient is taking aspirin or any other type of salicylate, it can interfere with the action of probenecid. It should not be used with these drugs. It inhibits the renal excretion of several drugs, including indomethacin and sulfonamides. And with these drugs, dosages of these prescribed drugs need to be reduced. And note here that aspirin and indomethacin are often other treatments for gout, and so this is something I would want to ask my patient before starting them on any probenecid type therapy. Just as a reminder, know the mechanism of action with probenecid, remembering that this is the drug that helps us to pee out the uric acid. This slide here does show the pharmacokinetics of the medications we've talked about. I would like you to focus on allopurinol, febuxostat, and probenecid, and knowing that the last one, Chrysaxa, is a drug that is newer on the market. We don't have a lot of pharmacokinetic information, but we do know that it can be dosed less frequently because the half-life is longer. The next few slides will help you to understand how the prescriptive therapy fits into the diagnosis of gout, starting with how you should treat them when a diagnosis of gout has been established. Take some time to look through this management, and you will revisit this in your learning when you go over gout and pathophysiology, as well as your advanced practice course. This algorithm is showing you the management of acute gout and the anti-inflammatory prophylaxis of gout. I would encourage you to use these algorithms as you go back into your slide deck to study in your textbook, and to make sure that you understand initial, first line, second line prophylaxis, acute versus a long-term management.